Hi, Jen.
Hi, Bethany.
How are you today?
Great.
Do you notice anything different about me?
No. Should I?
I changed my part.
What?
I changed my hair part.
What is it normally?
It's over to the left side, but I
Oh.
put it down the middle because every time we record, I realize that it looks like I don't really have a lot of hair. I mean, I already know I have thin hair.
Your hair looks great.
Thanks.
I do
Okay,
notice
great.
that.
I'm trying to shift it up a little bit for us today.
Okay, thank you.
You're
Thank you
welcome.
for letting us know.
So I'm here with the butt cut, and I'm kind of liking it.
Yeah, no, it does look good.
Yeah, maybe I'll like my clips a little bit better.
Interesting. I think that's like the new trend is actually to go back to the side part, away from the middle part, but it suits you.
So I'm already off trend. I missed it.
Just a few years behind.
Okay, well.
It looks great.
On to our topic today, which is going to be very information heavy, but valuable.
Yeah, I think so. We don't have to make it too long, but it's just one of those things that actually, when I was thinking about the topic, well, let me say what it is.
Okay.
We're going to be talking about things you should know about your hospital because not all hospitals are created equal. If you have the ability to choose your own hospital and you're interested in these things, but even if you don't have the ability to choose, which we know many people don't because of who your OB is, what your insurance is, what your location is, it's still important to understand these things so that you can be more prepared and know what is possible at one hospital versus another. So what were we going to say before that?
I
forget.
I forget now too. See, I'm having a mom brain day too because actually before I was going to tell you about my hair difference and see if you even noticed, all my kids wanted was popsicles. I have 3 boxes of popsicles that are just sitting in my car right now, melting away.
Well, I actually just stocked up on popsicles because it's about to be 4th of July weekend. Which
I know, that's why I got 3 popsicles to bring over to your house.
This is prime popsicle season.
I know.
For sure. It's
Anyway.
okay. I'll get more.
I think let's just normalize that mom brain never goes away. Because that's the kind of day I feel like I've been having today.
I mean, it might get worse over time.
No, I'm going to take a bunch of supplements to make sure that doesn't happen.
Old. I know.
But no, welcome to 40, Jen, by the way.
I'm 40 now.
You are 40 now. Does it feel good?
What will this year bring?
I don't know. I think a lot of good things.
So.
I mean, it's already starting out strong. I can't even remember our topic.
Promise we'll get to something valuable.
Okay, why do you think that this topic is so important? And how did you come up with wanting to have this topic?
Well, I thought about just talking about OB anesthesia in particular. I was on another podcast called Lean Out, which it's mostly for physician women who have taken different kinds of career paths and discussing how they've maybe taken steps away but still continue to be in medicine or doing different things in medicine. It's for all different kinds of physicians. Not everyone understands acutely what everyone else does for work. So she was asking me about OB anesthesia, and I wanted to talk about that a little bit. What is OB anesthesia? Why it is a specialized field, and there aren't exactly quote unquote OB anesthesiologists available everywhere. But then I thought more broadly, let's talk about all the differences in hospitals, because I will tell you, I did not know a lot of these things even until I started applying for jobs.
I was just going to say, I don't think I recognized how many differences there were either. We both worked at a similar, very large institution. So I don't know why I just maybe thought that
I think everything's the same.
Everything's the same, but you're right. It's dramatically different, and it's super important for people to be aware of those differences so that if you are wanting especially
you're particularly worried about something.
Right, exactly. Yeah.
Like if there's a certain thing that's brought you to us, a certain issue that, you're having a C-section, or even if you're planning a VBAC, we know that not all hospitals support VBACs, and I think you might understand a little bit why, because we've always said why. Why doesn't every hospital support a VBAC? But when you look at the qualifications for some of these hospitals, first of all, not all hospitals deliver babies, right? But then just looking at the ones that do, there's a baseline level for what.
Okay, wait, hold on. What did you just say? Not all hospitals deliver babies?
Right. Yeah. You have to have a maternity unit to deliver a baby.
Well, I know that, but doesn't every hospital have a maternity unit? What?
No, they close maternity units. Some of them are just not very busy, and it actually becomes it's bad and good. It's bad because now there are less places for people to go, and especially when you live where there's not many hospitals around. But on the other hand, these maternity units, they are sometimes shut down because they do so few deliveries that they don't have the experience, they don't have the staffing, and things don't go the way that they should, and they just don't have all the systems in place if they don't do it very often. If they only have 100 deliveries a year, it's all about experience. So of course, some of these hospitals that we're going to be talking about that have a lot of more resources, these are hospitals that also do more deliveries.
Right.
So how can you really pick? Do you want the one that does 1 million deliveries, but they're very busy, but they have all the staff? It's you try to match the staffing and the resources with the patient population, what the patients need, how likely it will be that they'll have a patient with a certain condition that'll come in. They're not going to just have that available if it's a rare thing and there's not that many patients coming in.
Okay.
Okay.
I'm already being taught something.
But so should I talk about OB anesthesia real quick?
Yeah.
So I love OB anesthesia. It is obviously. So to become an anesthesiologist, you go to medical school, which is 4 years, and then you have to go to a residency to choose what kind of doctor you're going to be. So you can go into internal medicine and become a primary care physician or a subspecialist like a gastroenterologist or a cardiologist or a hematologist, or you can go to surgery or OBGYN, et cetera, et cetera. So for anesthesia, there are, a few fellowship options. So then you become subspecialized in a certain type of anesthesia. So that could be pediatric anesthesiology, cardiac anesthesiology, so specializing in doing heart surgeries. What are the other ones? Regional anesthesia, so doing nerve blocks and such, critical care. And then there's some ones that are smaller, like neuroanesthesia, that are a little more specialized. But OB anesthesia is one of them. And so we specialize in really fully understanding the physiology of pregnant women and taking care of them before, during, and after pregnancy. So, for example, at a high level, there's doing fetal surgery, right? When someone's pregnant and needs to have surgery, which happens everywhere. That's not terribly uncommon. And we do a lot of patient safety type stuff, I think is a big thing, creating protocols and looking at emergency scenarios and how to improve them. Also dealing with really high risk moms. So things that you don't see very often. So women with heart conditions, lung conditions, things that really change the way we manage the patient when they're coming in for delivery, whether that's via C-section or vaginal delivery. So we spent a year doing that. All the fellowships are a year. It's the same length as someone who learns how to specialize in heart surgery or something like that. But it really does allow us to think outside the box, I think, and we're always coming up with new ideas and making what we do for patients better for them in so many different ways, whether it's reducing side effects or the patient experience and all of this. But we're tailoring it to the patient. We're not just learning like a singular dose and doing it the same way every single time for every single patient, is I think what makes us unique. Yeah. So I'm going to talk about something called maternal levels of care, which is something that ACOG does to classify hospitals according to the resources that they have. It's sort of the same as NICU levels, so it's 1 through 4, with 4 being the highest level of care, and having a fellowship-trained OB anesthesiologist on staff at all times in the hospital, physically in the hospital, is one of the qualifications to be a level 4 maternal care center. So it's valuable. And then you go all the way down to, and just talking about anesthesia, I guess we'll just start with anesthesia. This is what boggles my mind. I came from where we train. We usually train at an academic hospital, at a teaching hospital, where every single anesthesiologist who was on labor and delivery was fellowship trained, specialized. This is what they do. This is their passion. Now I think where I train, there's actually at least 2 fellowship trained OB anesthesiologists physically on labor and delivery 24 hours a day.
Wow.
So it used to be 2 or more during the day, but then maybe only 1 at night. Now it's at least 2, 24 hours a day. And then you go to some other hospitals and the anesthesiologist doesn't even have to be physically present in the hospital. And they certainly aren't necessarily covering just labor and delivery, meaning that they're there also for the emergency surgery that comes up or anything else, any other anesthesia needs that come up in the hospital. They're just there to do whatever happens. So should we go through?
Yeah.
Is any of this interesting?
No, it is. It very much is. It's a safety for mom and baby. And it's like that. We talk about coping and anxiety. Like that's going to reduce your anxiety if you're knowing what level hospital you're at. Who are you asking that question to? Your OB?
Yeah, I guess you could. Your OB might know. You could maybe look it up. A level 4 hospital is really going to be your big regional academic centers. I think it's not going to be hard to miss those, I guess. But then it's the 1, 2, and 3 that you're going to look at a little bit more closely. 3 also has a lot available and sometimes acts as the regional center for areas of the country where there isn't a bigger academic, where they're training people like me, you know. There's only so many residencies in the United States, and they can do most of the stuff. There are some things that, depending on what your situation is, like, again, like I said, what is your issue? Do you have a placenta previa? Do you have a placenta accreta? Did you have a postpartum hemorrhage in a previous delivery? Then you might be thinking, okay, what do I want available at my hospital if I were to have a complication related to that problem that I have or the problem that I had before? And this is where I think it becomes interesting. So maybe once I start talking about it.
What are you doing now?
I mean, like telling you what it is.
Okay.
So let's start with, it's all about the level of training of the clinicians and also their availability, but also things like the blood bank, which I think is huge.
Yeah.
Because you can't believe that the availability of blood products is vastly different depending on which type of hospital you're at. But also radiology, availability of CT scans or MRIs, and then also the availability of subspecialists that aren't necessarily related to OB, but sometimes we need to call in like a cardiologist or a hematologist, something like that. And then the NICU. The NICU, by the way, it's not in the maternal levels of care. It's separate. Because it's maternal.
Right. Wait, do you want to know a really interesting fact about the NICU?
Sure.
Do you want to know where the very first NICU was?
Where?
In 1960 at Yale New Haven.
Oh,
isn't that interesting?
Connecticut.
I know.
That is interesting. How do you know that?
Because I was doing research, Jen.
That is a fun fact.
Isn't that a fun fact? Actually, it's a fact I wish I would have known because I delivered in Connecticut, but not at that hospital. And because Sable was a NICU baby, I wish somebody would have told me. Like, I don't know that there's,
that there is a higher, like there are
yeah,
levels.
like, I knew there were different levels, obviously, but I don't know. I feel like that fact would have been so comforting to me to be like, okay, so if something really starts trending down, that he'll be transported there. Because I knew that that was, for me, that was going to be the closest level 4 NICU.
Yeah. I think regardless of where you deliver, knowing where your closest 4 or at least 3 is.
Yes.
And all of these lower level hospitals, they have to have the ability to transfer, to stabilize and transfer should mom or baby need a higher level of care. But I do.
That's, I think, a really important statement to say again, too, because I don't think that if you're in a really traumatic moment and maybe your spouse doesn't know that either, like that is something that is going to be covered by your insurance, hopefully. Maybe not obvious at 100%. We know insurance has a lot of things, but
I hate insurance.
I know, me too. But that is the responsibility of the hospital to ensure you can be transported.
Yeah, there has to be a plan in place always for these other levels of care. So it starts out with, it's a different thing, but there's a birth center, right? And they have their own sets of qualifications. If you're listening to this, you've probably had a C-section or you're having a C-section, probably not qualifying for a birth center. But the first basic level of care, so I don't know, I just think this is so interesting. They have to have an OB who can do a C-section readily available. Mm-hmm. That doesn't mean in the hospital. That means, who knows? That means, I don't know what that means.
Like within 30 minutes, they're arriving to this hospital?
They literally don't say.
Okay.
They don't say. Okay. They just say within a time that's
reasonable.
They even use I should have written down the exact wording, but it's quite vague. So then as far as the anesthesia, someone has to also be readily available. So that could be I mean, I know at certain hospitals, there's sometimes like apartment buildings that people stay at nearby, or if you live close enough that you can be called in, that some anesthesia provider is, quote, readily available, but it doesn't have to be an anesthesiologist, a physician. It can be a CRNA or an anesthesia assistant, but some type of anesthesia provider would be readily available. That's kind of it. Oh, you have to have a lab testing and a blood bank.
Okay.
But the blood bank doesn't have to be fully stocked, just some kind of something blood bank. So that's like basic hospital.
Yeah. Okay.
Stuff.
Okay. Got it.
At least in the United States, right?
Got it.
And then basic ultrasound. So probably just a bedside ultrasound that you can look and see something, but you're not going to get advanced scans there, advanced with Doppler imaging, looking at the blood flow to the baby or something that an MFM would do. So for a level 2, you're going to have advanced imaging available at the hospital. So a CT scan, an MRI scan, an echocardiogram, but it doesn't have to be readily available at all times. Maybe just during the day, maybe just during the week, but it's somewhere in the hospital potentially available. And then an MFM has to be available. So an MFM is a maternal fetal medicine specialist. So that is an OB who has trained in understanding high risk situations for mom and baby. And they have to just be available for consultation by the phone. That was the other thing that I thought was really interesting.
Oh, that's interesting.
Because where I grew up trained, the MFMs worked on labor and delivery. They were the people actually doing the surgeries, doing the deliveries. There was a whole group. Not everyone was an MFM, but there was always an MFM physically there taking care of women on the floor. And that's just actually quite uncommon.
Yeah.
So some places you may not even have that available by consultation, but with a level 2, at least you could pick up the phone or do a telemedicine consult if there is some high-risk situation that presents itself and they need some extra support and advice, I guess, via this MFM.
When I was interviewing my OBs, I knew I needed to be with an MFM, but it was also one of my questions. I think it's a good question to ask is, do you have an MFM that you recommend or that you work closely with? Because you might go into your appointments and not think you need an MFM, and then something shifts in the pregnancy, and then you need to have that resource. So that actually made a big difference on who I chose for my second OB once I moved out to Connecticut, was who I knew.
But your second OB was not an MFM.
No.
You just consulted with an MFM.
Correct. Right. Like
Whereas
she worked
in
closely with
in
someone.
New York City, your MFM would have been your doctor.
Exactly.
Would be your doctor.
Exactly. Yeah.
It's very different.
Yeah, it was different.
And that's how they work. So some MFMs, they don't deliver babies.
Yeah.
They simply do the consults and the ultrasound. Not simply, they do a lot of stuff. But there's different flavors of MFMs.
Totally.
Yeah.
Well, if you're worried about continuity of care, like for me with my first.
You knew that they would communicate.
Correct.
Yes.
Correct. Yeah. Because to your point, exactly, my MFM did my C-section, whereas when I moved out here, I knew my OB was going to be performing the C-section, but if she needed, I'd already developed a relationship with the MFM that I was seeing as well, and they closely communicated. So I guess if anything shifted or she needed additional support, I don't know, like they would have worked together in a way.
Did you ever, your first was in the city? Or
Yeah.
Did you ever think about going back to New York to deliver?
I did, but then I realized that the MFM that I had, who was my main doctor, he went out of town. And so I saw this other MFM that he worked closely with. And that MFM actually happened to have an office out in Connecticut as well. So that's also why I chose my OB out here, because I already knew that MFM.
And like the closeness. I mean, I've had this mental exercise before. You know, you want to be close to your hospital if you need to go in and get checked.
Yes.
And it's not nothing.
Yeah. And because I already had one at home, that wasn't going to be really that realistic for me to be
You already had a baby. Yeah.
going back and forth between Connecticut and New York.
Yeah, makes sense. For level 3, you have the board certified OBGYN physically present. Again, MFM available by consult. And this is the first time that you have to have a blood bank with all blood components available.
Wow. Level 3.
Level 3.
That's wild.
I know. Everyone go donate blood. We've said this before.
I know.
But that is, I mean, maybe not now if you're pregnant. But,
Right.
but
Do you know what your blood type is, Jen?
I do. I am. Do you want to know?
I do want to know. I think it's I'm blown away at how many people don't know their blood type, actually.
Yeah, I'm O.
You're O, okay. I'm B positive.
I'm the universal donor.
Right. But it's important to know because, like, for me, B positive,
Yeah,
I think
I'm
it's
O positive.
20% of the population is B positive. You're going to know if you're a negative because you probably got ROGAM.
Yeah,
You
exactly.
did get ROGAM. But that was really important for me to know because I'm like, oh, I have one that is a little bit more unique,
Ooh,
you know.
exciting. And I know that Paul is AB somehow. I don't know how I know that. And so then my kids like have to be either B or A, but I don't know what they are.
Another thing for us to figure out.
So interesting. But yeah, again, where I trained, you didn't have to worry about the blood bank. Like
Right.
if somebody is bleeding, we had so many different options. It came so quickly. There was a specific protocol for obstetric hemorrhage versus other kinds of hemorrhage because there is a little slight difference in bleeding. There's something called cryoprecipitate that you want to give sooner in obstetric patients because of the mechanism of the bleeding. There's just all these policies in place. People are ready. The blood bank understands OB. During my fellowship, I had to do a little rotation in the blood bank where I pretended I was a pathologist and did blood bank stuff for a month, which was so fascinating. Anyway, so that's the first time you're going to need a full blood bank. So I would certainly, if you have any concerns about bleeding, I would ask about the blood bank.
Yeah.
And if your OB doesn't, I mean, your OB will know, but you can call and talk to somebody at the blood bank and see what their procedures are, what they have available. This is getting me into another thing, but I think it's important because it was on my mind recently. Because I'm trying to think of a social media post for my new Jen Wagner MD Instagram. Please follow me.
Which I love it so much, Jen.
But one thing I wish people knew is I get so upset when women are anemic during pregnancy and it's not adequately treated. And it could have been,
right?
You know, like someone didn't tell them. Maybe the iron isn't working. Maybe the iron, it's hard for you to take, which happens. But then there's iron infusions, or see a hematologist, see what they can do, because you really want your blood counts to be optimized before you go in to have a baby.
That's a very good point.
It's not right, honestly, when someone hasn't done it as much as you can do to optimize that, because everyone bleeds.
Everyone bleeds,
when
right.
Have a baby. And so you want to be, I don't know. I just think that's something that's really important. And when we talk about reducing blood transfusions, sometimes people go and donate their own blood. If you've had your blood checked and you have certain antibodies or something people get, if anyone's ever said anything like that to you, make sure that that is something that you can look into before you go in and have your baby, and make sure that they have the blood that's going to be what you need, for example.
Right.
Because that has happened. That does happen where you get your type-in screen. That's why I love the idea of getting the type-in screen 2 days before. Like, why do we wait till the day of surgery?
Right.
Like, get it 2 days before. See if there's anything weird, which happens because we're carrying literally other humans inside of us that have different blood types.
Okay, but so I'm going to pause you and highlight that a little bit more. So you can 100% ask to have that appointment 2 days prior to your scheduled or your expected due date.
Getting the type-in screen early.
Correct.
So everyone needs a type-in screen before they have surgery. And if the type-in screen comes back with some kind of antibody that you have, then I don't start the surgery until I know that the blood bank has blood available for that patient, which can cause delays and people get mad at me. But
it's a serious safety measure that you're taking.
Even if you don't, chances are I'm not going to need it, but why would I take
the risk?
That risk. And so some places do it 2 days before, some do it the day of. And the reason why we did it 2 days before, if you're wondering, is because once in a blue, that something like this will come up, and then the blood bank will know, everyone will know that we're ready to go when that person comes in for I'm talking about a planned C-section.
Yeah.
Usually with pregnant women, the type-in screen has to be pretty close to when you would potentially need to be given blood. So it can't be like months and months before they need to do it again. It's just something to think about, and whatever the policies are, and especially if you're worried about bleeding. So optimize any anemia, make sure you have a type-in screen that's been looked at, and that the blood bank is aware that they have what you would need should you need it.
Super important.
So back to the subspecialty care centers. So these are the these are really great hospitals. They have a lot of stuff. They have some basic interventional radiology. This is something that as an OB anesthesiologist, I love to hear. So
Why?
why? Because that would mean something like a uterine artery embolization. So this is, again, having to do with bleeding instead of going straight to a hysterectomy, which is something that can be done anywhere. But if it's something that we think that you can slow it down with other procedures, which there are various, one of them would be a uterine artery embolization, which is a procedure that kind of stops the blood flow to the uterus to allow you to keep the uterus. So that's
No, that's huge.
Do you want to know if your hospital has that?
Well, of course, especially too if like, you want to have multiple children. I mean, you're also thinking like not only about this delivery, but I think it's important to have information about a hospital so that if you want to have more children, I think that's comforting.
A little scary.
Why?
I don't know. Is it scary? Am I scaring people?
I don't think you're scaring people. I think you're alerting people to like think about things that probably they were not thinking about at all.
Right.
And I mean,
Like you hope you don't ever have to need it.
well, of course. But if you do, to know that you did your due diligence
That's why
of collecting as much information as possible, that's going to help give you a better success of processing everything.
Whenever I put in a second IV for a patient that has a few extra risk factors, that's what I always try to tell them. Is it's better to have it and not need it,
Yeah.
I think. I mean,
Yeah. It's like wearing your seatbelt every day.
Yeah.
Don't like drive thinking you're going to get in an accident every 2 seconds, but what if
Right.
that terrible thing happens and you have your seatbelt on?
right.
You're setting yourself up for safety before you even have the accident.
Gotta wear your seatbelt.
Yeah. God, my kids and their seatbelts don't even get me started.
So then the other thing is the ICUs, which I also find really interesting and variable. So with a level 3, you have to have an ICU in the hospital that will accept pregnant or postpartum women. And that would be staffed by an ICU physician. When we get to level 4, there are places with actual obstetric ICUs. They're run by MFMs who are board certified also in critical care. Really high level understanding of not just critical care, but pregnant or postpartum people that need extra support and have all the experience managing these types of things. So I think that's really cool that exists in some places.
That is amazing. So as a patient, or if you're listening to this and you have an upcoming surgery, collecting information like, so if my hospital is a level 2 or level 3, can somebody let me know where level 4 hospital would be?
Yeah.
If I were to need that.
Yeah, level 3 has most of the things. Level 4, you're getting into the availability of a neurosurgeon, a cardiac surgeon. So this is when Kaylee Summers talks about the availability of ECMO and how she would choose this highest level of care because of her experience. That's where you get that. That's where you have literally there's going to be a heart surgeon that's physically present in the hospital, available at all times, right?
Yeah.
I think there's a couple other things to look at that make this a little simpler. So if a hospital does heart surgery, not all hospitals do heart surgery. When a hospital does heart surgery, somewhere there's a heart surgeon, whether they're there all the time or not.
Right.
There's someone you can call. And heart surgery requires a lot of blood products. So you know that they're going to have more available, including a lot of the special tests that we do when it comes to hemorrhages and just the special equipment that's needed for heart surgery. It seems scary, but those things, they come in handy with any bleeding patient, which, could happen with any pregnancy or birth. And then the other thing is, so looking at if it's a trauma hospital, so those also have like all the latest and greatest of everything when it comes to this type of stuff. Hospitals also have levels for trauma, so level 1, so opposite in this case, level 1 trauma center is the highest level. That might be also a quick way of just getting an idea for what might be available at the hospital. And so the level 3, the anesthesiologists are in-house with the level 3, and then for level 4, you have the actual OB fellowship trained in-house at all times for level 4.
Is the hospital you're at a level 3?
I don't know. I think so. I don't know how easy it is to find this stuff out, but I just think it's interesting what ACOG chose to be important and
That's a good point.
kind of how it goes up. You might have things that are important to you. I want to make sure that there's an anesthesiologist who's OB trained? Just no, but who's
I would.
yeah. Even if you're going in for, let's say you're going for a VBAC and you want to make sure that you don't have to wait forever for an epidural. Accreta is a word that I think some of our listeners might have heard of because it's something we talk about as a risk with increasing C-sections, especially after 5 or 6 C-sections. But if you're worried about that, you could call up and ask if they have certain programs specifically for Accreta, certain protocols. There's multidisciplinary teams. When I worked at a place that I would consider an Accreta center, there's a group of individuals that regularly met and discussed potential Accreta cases. And they included hematology, general surgery, gyn-onc, anesthesia, nursing, et cetera, et cetera. It was always a big group of people and they would meet every so often. And so those are the places that really do Accretas a lot. They have everything in place. They know what they're doing. There are other places that do Accretas sometimes. So I mean, if you have ever heard that word Accreta, like every hospital should be capable of managing this. But if there's an option that's not so much farther away that does this all the time or once a month versus twice a year, you know, right. It's just kind of a good thing to know and to ask. I think a lot of times I've noticed, although I think I probably work at a level 3 right now, but certainly we have Yale. I don't work at Yale. People don't want to have to transfer their hospital.
Right.
I think it comes with a lot of emotions. And, you know, we don't do it unless we really think that there might be something that they have, and especially something they have 24 hours, 7 days a week, that another hospital might not have. But I know that people are not happy. They don't want to make that change because they're having to change their OB too.
Right.
So I don't know. I just wanted to point that out, that I know that it can be emotionally really taxing if you're told you have to, you know, along with whatever it is that's going on.
That's where hopefully having a really good conversation with your OB if you're needing to make a change, or if you start collecting information and you think to yourself, like, I don't know if this hospital is going to best support me. Being able, again, why we always go back to you should have try to have an OB that you feel safe with and you feel like you could have a collaborative conversation to make a change if one needs to be made.
Yeah, and the OBs don't want to lose you as a patient either.
Of course not.
It's always like a very big deal, just again from personal perspective, to say we need to transfer this patient out because we're not the absolute safest place. And it's not saying we couldn't help you, but we want you to be really as safe as possible. It's not something that is taken lightly on any side.
No, yeah. It's emotional for both parties.
Yeah, and maybe understanding, okay, what are the other things that this other hospital has that mine doesn't? Might, if you're faced with that choice or that recommendation, it might help you understand it a little bit more.
Right, and process it better.
Yeah, so I think that's all I have. Unless you want to talk about NICU.
I want to talk about the NICU.
I just have some basic stuff. Level 1 seems to be just basic care. Level 2, they could do some respiratory support, but only for a short period of time. Sometimes they look at gestational age or birth weight of the baby to say whether or not it's appropriate for a certain level of care. So greater than 32 weeks for level 2, 32 weeks. Level 3, 28 weeks. Level 4 is micro-preemies, specifically, you know, trained in taking care of these, the itty bitties.
The little, I think it's a really good question to ask your OB about what level NICU your hospital has, regardless of mode of delivery. I think that's just a piece of knowledge that you should definitely have going into your delivery.
Yeah, 100%. That would be one of the big things I would be thinking about for sure.
Yeah. I have some just little tidbit things that I would ask a hospital. One, this is one I get all the time from my clients. Am I guaranteed a private room? That actually makes a very big deal for a lot of people, especially if you're having a C-section. They're like, my partner is not leaving me in a room alone. I want to have them with me, and vaginal as well.
So because if you don't have a private room, then you can't.
So asking ahead of time, are you guaranteed a private room? If not, how could I get on the list for the hospital where I was that it was
so New York City.
Based. It is. It was based on the time in which the baby was born, and then they put your name on the wait list. But you have to be advocating for yourself and saying you want a private room if you want a private room,
or you might have to pay for it,
or you might have to pay for it. Understanding ahead of time what that would cost, what your insurance is going to cover versus what would be out of pocket, and if you are going to have some out of pocket expenses, put that on your baby list registry.
Oh, I love that.
People can help you.
Give me a private room.
Give me a private room. But seriously, that is something that you should know ahead of time. That is going to decrease your anxiety, knowing that was huge for me because where I delivered my first, you were not guaranteed a private room. Where I delivered my other two, when I called the hospital to ask them that, they were like, what?
They were like, of course.
Everybody gets a private
Yeah.
room. But that's really important. Like, I was like, oh, okay. Like, I know my husband can stay with me overnight. And that was really, really important for me.
What else do people ask you?
What else?
Relevant to this audience. I listened to another podcast that was sort of saying the same topic.
Okay.
And it was like, what options do you have for unmedicated births? Do you have birth tubs, et cetera, et cetera? I wish you could find out, you know, like how nice are your nurses and your anesthesiologists?
What's the food going to be like?
What's the food going to be like?
All those things.
It's never great, you know?
I mean, can my husband stay over or my partner stay overnight? I feel like is a very common question. Even if they do have a private room, they just they want that security of knowing someone can stay with them. Or
And what are their accommodations?
And what are the accommodations? Do they have a bed? Is it a lazy boy that they're going to be sleeping in? Because that may make a difference for your partner, your support person, if they want to stay with you or not. And if you have other children at home, that's also like for me, I knew I wanted my husband to go back home. So I had my sister stay with me. But I asked that question, like, is it okay if they switch? You know, could he stay one night and then you switch and then my sister stays another night? And just hearing, I mean, I knew pretty much what the answer was going to be, but just hearing that concrete yes, I was like, all right, I'm putting a plan together. I know I don't really say plan that much, but I had a plan in place so that like if I needed to stay 4 nights, 5 nights, what, you know, that mattered to me, who was going to be with me.
Yeah.
And I don't know. I mean, obviously we both had 2020 babies. So, you know, so many protocols have shifted since that time frame. And I think trending better. I think it's pretty much, you know, recognizing that having a support person stay with a new mom is a vital part to their healing.
And then there's the nursery aspects. I think so many hospitals are trending towards the baby rooming in. It's almost, I mean, I guess it's still worth mentioning, but the availability of the nursery as well.
Oh, it's definitely worth mentioning. You should ask that. I utilized the nursery for sure. I needed to sleep. It's okay to say I need to sleep. Can my baby go to the nursery for a little bit?
Yeah. And so I think less and less, the availability of the nursery is going down as the rooming in goes up.
Right.
For better, for worse.
Yeah.
Depending on what you care about.
Yeah.
But
it's a good question to ask.
Understanding.
I mean, I think it's a good thing, just like if you're listening to this and you're like, what did they just say? Re-listen with a pen and paper and write some of these things down, because if it's going to make you feel less anxious going into the process, more control, that's what it's really about.
And like figure out which aspects might be something that's of particular concern to you, because everybody's different. We all have different things that worry us and different things that, this particular thing would really not be okay if I didn't have it, if the hospital didn't have it, if it wasn't available to me.
Yeah. It's a good exercise to do with your partner too, because maybe they're going to ask about certain things that you didn't think about. Are we ready to wrap it up?
Yep.
Okay. So it's very hot here right now, obviously. And so it really got me thinking about how are we helping to support a mom when I know my 3rd trimester, I also had summer babies. I was hot all the time. And so I'm going to bring out one of my favorite tools. So this is like literally the easiest thing to do. It's a Spritz bottle that I put filtered water in and aloe vera, and you put this in the fridge. It's super soothing to the skin. This is also a good thing. So newborn babies, we don't want to put sunscreen on them. And this was jarring my mind the other day because our girlfriend had her baby and she was like, I think it's a little too hot for him to be outside right now. And I was like, well, honestly, you should have like a spritzer on you that you can spritz the feet, the legs, and cool off the baby, and spritz yourself too and cool yourself off, because end of pregnancy, we know with our blood volume doubling, tripling, and also after delivery with the hormonal shifts, you get those hot flashes. And I think keeping something like this on you at all times is gold.
Sounds very refreshing.
Also, something that I love, one of my favorite tips is, especially in the summertime, is before you go to bed, you could spritz this on your pillowcase. Take the pillowcase off your pillow, spritz your pillowcase, put it in the freezer, and then before you go to bed, put that pillowcase back on your pillow, and you are going to go to bed feeling so refreshed, so less hot.
And he runs hot.
In pregnancy, didn't you remember
Yeah.
that? Didn't you remember like trying to go to bed and you're like, I'm so freaking uncomfortable. I'm also hot. You don't really know what you need anymore. You're like trying to sleep on your left side, your right side, trying to avoid the back, but
Yeah.
you know, all those things. I feel like the little pillowcase in the freezer, it's a good one.
Put all your sheets in the freezer.
Yeah.
No, I like it.
Try it, Jen.
Great. I feel like
You're in
very
your
spotlight.
40s. You might get hot flashes
I
now.
know.
You might need this.
All right. Well, thanks for listening, everyone. Don't forget to download our free C-section guide on our website, csxpodcast.com. Follow us on Instagram, the CSX Podcast.
Yeah.
And if you want to follow me, Jen Wagner, MD, also on Instagram. Anything else?
I think that's it.
All right. See you next week.
Bye.
Bye.